Hello, everybody. I'm very happy to have with us an expert, a dentist who's gone on to do things other than dental. It's a very interesting story, I'm sure. Right now, we have with us Dr. Prashul Joshi. Let's listen to him. Over to you, Doctor.
Thank you very much, sir, and good evening to all of you. Firstly, I would like to thank Dr. Subodh sir, for giving me this opportunity to share my thoughts. I'm honored to be part of your video series of young Indians and their inspired vision. So, firstly, I would like to introduce myself. I have been raised in the family of doctors. Right from my grandfather, he was the director of medical services in the state of Madhya Pradesh. My father, who recently retired, served as medical officer in Gujarat government. So, right from my childhood, I had inclination towards medical sciences. So it would be appropriate to say that I used to remember the names of medicines and diseases better than the names of my own relatives since from childhood. So after that, I did my schooling from Kendras Vidyalaya Surat and did my bachelor's in dental surgery from Indore. My first 1 year of undergraduate internship was completed during 2020, which made me clinically sound with various dental procedures. But what I observed that even with the government setup with the utmost cost effectiveness of treatment which are being delivered, we were facing certain social challenges which were not in our hands to control, such as unawareness, poverty, illiteracy, and multiple health issues from the patients. And during 2020, there was a time of COVID-19 as we all know. I got the exposure of working in health systems during the crisis situation. And I realized that to address these multidimensional challenges, I must join civil services to increase my outreach. So I started preparing for the entrance exams. Somehow I cleared some levels because in India it is having levels. So somehow I cleared some levels, but it was challenging and time taking because few results are still awaited. So, but it gave me insights of how the government works, what are the challenges, and what are the policies which are working to address them. It gave me a comprehensive understanding of subjects apart from the medical sciences. So later on, I got the opportunity to pursue my master degree in public health from the Indian Institute of Public Health, Gandhinagar, with the same vision of shifting patient-centric care to community-centric interventions. And right now, I am in third semester of my course. So it was a journey full of transitions, but ultimately the basic knowledge of various subjects led me to understand the problems in a technically comprehensive way. So even if I fail in certain exams and even if I was not able to clear the civil services exams, it made me realize how what are the original challenges apart from the medical sciences. So that was my introduction, sir. I firstly,
Yeah, go ahead.
firstly, I would like to share certain of my experiences. As a part of my public health course, I have to complete 2 months of internship. So I took my internship at maternal and child health program, which is one of the largest national health program in the country. So it gave me on-ground reality check of implementation challenges from the community side as well as from the health system side. Particularly, what I did, I took the knowledge, attitude, and practice analysis of women-centric cancers. Women-centric cancers are like breast cancer, cervical cancer, and somehow. So I took knowledge, attitude, and practice analysis of women-centric cancers and compared my data with the WHO global order of the same. So, in my sample size of 50 women of reproductive age group, almost 95% don't have the knowledge about breast cancer and cervical cancer, and never had undergone the screening test for it, which itself signifies why we are at the top globally. And let me tell you, sir, both of these cancers are preventable in nature by early screening procedures. Even WHO is also emphasizing these days that HPV vaccine is ready to roll in the market and has to be included in the universal immunization program for the girls of 9 to 14 years of age. We are going to witness the HPV vaccine campaigns as well. So what I mean to say that these kind of cancers are highly preventable, but still India is contributing the highest burden globally, and even in Southeast Asia region, we are more higher in percentages as compared to China. So that's what I realized during my internship, and with the 50 women, I got to know the factors which are contributing to this burden. And before talking further, I would like to put some light on global disparity of health scenario. As you have observed, since you are living in US, it is one of the developed nations. So developed nations are having the burden of non-communicable diseases and lifestyle disorders like diabetes, hypertension, cancers, mental health issues, where these developed countries are having burden of infectious diseases such as malaria, dengue, Ebola virus in African region. But the countries like India, who are in developing stage and somehow World Bank classifies it into the LMICs, low and middle income countries, is facing the dual burden of diseases. Dual burden of diseases means we almost have equal percentage of diseases from the communicable disease factors and from the non-communicable diseases. So at the same time, we are dealing with both communicable and non-communicable diseases. So health is a multidimensional phenomenon which with various determinants, and the reason behind this dual burden is we can say unplanned urbanization, sedentary lifestyles, addictions, unawareness towards health, or I would say bipolarity towards health, because there are two types of people: the one who are hitting the gym in a very hard manner, and the other ones who are not doing anything. So, in my vision, they both are wrong. So, that is somehow we are dealing with the bipolarity of health awareness. Dietary habits are also implicating to these burdens. So, we are witnessing the epidemiological transition globally from infectious diseases to lifestyle disorders, as we have observed from trends. So there was like in 1940s, 50s, and 60s, there was more prevalence of infectious diseases like cholera, malaria, dengue, and whatnot. But now we are witnessing the shift from infectious to non-communicable and lifestyle disorders. We are having more prevalence of cardiovascular diseases, diabetes and hypertension. Every third person is hypertensive globally. So that's what the epidemiological transition we are witnessing globally right now. So I would say that health is not a biological issue. It's also an economic issue as well. Uh, Limited financing has been constant. We have not achieved Alma-Ata targets fully, but we did some significant efforts. India still spends less than 3% of GDP to the health, in which the large we have to manage the large human resources, infrastructure development, 35 plus national health programs, and over 50 crore beneficiaries. They have to be covered with this less than 3% of GDP. I was going through the WHO data, so what I came across that over 46% in health came from the out-of-pocket expenditure, which results in huge financial burden over various strata of Indian society. And majority of this out-of-pocket expenditure goes into the treatments of NCDs, like non-communicable diseases. So the economics of NCDs in India includes both direct and indirect costs. The direct cost is like what you are paying to the doctor, what you are paying to the health facility for the medicines. But the indirect cost, which includes time, loss of wages, inaccessibility of healthcare services in the remote areas, although we are trying hard for that, but still there are certain loopholes, challenges, difference. So these are some indirect costs. Like the laborer goes to the healthcare facility, his whole day got utilized. So he was not paid the wage of that day. So that's what he is paying the double cost for his healthcare services. And it, it is also interdependence of poverty and health and other social determinants. So there is an interdependence as well as coexistence of health and poverty. Even if we try to curb the healthcare services and we improve the healthcare services, the other determinants are not in our hands. As a healthcare professional, our duty is to deliver the quality healthcare, but we cannot eliminate or neutralize the poverty causing due to healthcare. So that's what our limitation is. How economics could help in structuring the health system in India. So we also have to apply the concepts of welfare economics and standard economics. As you are an economist, so you know better than me. It plays a major role in increasing the efficiency of health system in working. We have large workforce and nationwide programs. So by gradually increasing the health budget, it also help in enhancing the quality of care along with the increasing advancement, like giving grants to research and research and development things like that. Risk pooling can also be done by the insurance schemes. One of the classical example I have, the PMJAY scheme has covered 50 crore people, and it is a very strong effort by the government to curb the out-of-pocket expenditure. So that was a very strong step. We have also made Jan Aushadhi Kendras for affordable generic medicines because there was also a huge challenge of price of medicines, especially for medicines for the diabetes and hypertension and all these diseases. So by Jan Aushadhi Kendra, we are scaling up the affordable generic medicine disbursement. We are also doing exceptionally well in immunization. I would like to say that everybody has seen our vaccine potential during COVID-19. It needs to be strengthened, but we have that potential. So I would say resource allocation must also be done judiciously, and health technology assessment will be useful in the cost effectiveness evaluation of new drugs and diagnostic kits. Even in research, we also invent or develop a new diagnostic kits. It was my personal observation that during the cervical cancer screening, what I observed that during my internship that we cannot ensure privacy everywhere. So in the upcoming decades, like we have talked about technology, so technology have its own advancements. So we can develop certain cervical cancer diagnostic kits which are home based, just like pregnancy kits, because in a vast country we cannot able to ensure the privacy of everyone for screening. That is why. Other than that, for non-communicable diseases, we can follow the WHO best buys. They have a prescribed list, and even right now, the government is also very much interested in the curbing the salt utilization and oil utilization in the street foods and all cafeterias, etc. So government is quite interested in the rolling out the nutrition and NCD programs. Robust awareness campaigns, communication, and promotion activities by our ground healthcare workers is in need of an hour. We have a large workforce of ground healthcare workers like ASHAs, ANMs, Anganwadi workers. But what I observe that they are also overburdened because their salaries are not fixed. They are incentivized due to their activities because Indian health system is decentralized. So in India, health is a state subject. Although we have ministry for guidelines for framing the guidelines, but every state have its own challenges. Every state have its own demographical challenges, geographical challenges. So there's also disparity in implementing the so health was put into the state subject by the constitution, but every state, the ground level healthcare workers like ASHAs, ANM, who are conducting outreach sessions must be strengthened. They are overburdened, what I would like to say that making the healthcare system sustainable requires multidisciplinary approach. As I already said, that health is a multidimensional phenomenon. So multidisciplinary approach, we have to address certain social determinants like illiteracy, poverty, overpopulation, poor sanitation. Illiteracy because even I also observed my 50 samples of women. There were almost 98% women were illiterate. I would not say illiterate, but they were only matriculate. They were not graduate. So if they are not graduate enough, they won't be able to know about their body. It is the sole issue. So we have to control the illiteracy, poverty, overpopulation, poor sanitation, etc. So it's a collaborative approach which must also have the elements of public-private partnerships uh, and increase the role of academia and strong political will. Another high example, like we eradicated polio and smallpox due to political will as well as from the determined healthcare professionals. So that's what we need right now. That's, uh, we survive pandemics, so we have potential to make our system better and stronger. Strengthening the primary healthcare facilities, just like, for example, they have included the NCD screening, like BP, at least BP and diabetes screening into the public primary healthcare centers. So it is one of the steps towards strengthening them. Incentivize health workers and lessons to learn from the various countries and models. Although we cannot copy the various models of country because we have our own challenges. We are a vast country with lots of diversity and we are quite populated country. So we can learn the lessons and modify it for our uses. So that's what I would like to say because to go into the deeper insights, into technical.
Well, thank you so much, Prashul. That was I should say that I'm happy to hear you say all these things because those are also my views. Okay. But let's follow up on a couple of things that you said. One of them is, well, let's look at two. One of them is local and one of them is international.
Local,
Local, Indian, and the
correct.
other is international. So let me first take the international part. You said we eradicated smallpox, etc., and then we faced COVID. Both of those are not controlled just by us, they are part of the world, right?
Yes, exactly.
Yes, it is an international effort, and the smallpox, the vaccine didn't come from us. And the urge to do it came from, I believe, WHO. And smallpox you cannot eradicate unless you've eradicated it all over the world because it's a communicable disease. So you can't say we have just done it in India and okay, we can rest. You can't rest because it has to be removed everywhere.
we
right?
actually eradicated it lately. No, not when the world was eradicated. We eradicated lately. And
Yeah,
for the polio, you mentioned it right that it was a WHO effort.
yeah,
But what happened? But we let me take you to the case of the African nations. The polio
yes.
is still prevalent there, and WHO is spending lots of their resources there. So, what emphasized the eradication programs and the campaign is the determination and dedication of the healthcare workers and their will. Because we also have the difficult terrain, difficult population, cultural
Yeah.
challenges, and so many barriers.
Hmm.
I have read the stories of WHO workers crossing the Kosi River in Bihar
Yeah.
for immunizing the children, and also any program gets successful because of its robust surveillance system. So we had a yes, it is a fact that WHO totally helped in that, but it was a collaborative and joint effort of the Indian government and the WHO. Because if it was solely on the international agencies, then we are having the case of African nations where so many diseases are still prevalent, which are preventable by vaccines. So
Okay, so I hear you. But I just want to make the point that in these days where we talk of Atmanirbhar, we should realize that look, this public health cannot be done just by ourselves. We need to have collaboration, right?
yes, yes,
And this is not something that diminishes us or reduces us, rather, it is a natural part of disease and problems worldwide. I mean, okay, fine, we have now for diabetes and weight loss the new medicines. And we cannot simply say, okay, they are foreign, we don't want them. I mean, that would not work, right? We have to accommodate it in our treatment system because they are effective, they work. So we need to simply not say that we will do it all ourselves. And there are some who would say, oh, well, in the ancient times, we didn't have all these problems. So we should go back to the ancient days. But those days are gone. Those days are gone. We cannot simply look back and say, yeah, we did have diabetes in the past, but we have it today, and we cannot simply say, look, we are not going to take these modern medications or the CGM because it's not invented in India. We can't do that. We have to have collaboration. And in the COVID times, it became clear that the international disease needs international collaboration. I just want to make that point and see what you say to that.
yes, and that's why I mentioned that public-private partnerships are the need of an hour, and that's what globalization has done to the healthcare system in the India. We have introduced new technologies through the international collaborations. Okay, and the vision of Atmanirbhar Bharat, as you mentioned, that was about more of dependency. That yes, we do welcome collaborations, we do welcome joint ventures, but somehow we must not be dependent on that because when the crisis situation comes, it will be very dreadful for any nation to be dependent on any other. So that's what to make India Atmanirbhar, we need collaboration. That's what my understanding about Atmanirbharta, that it is more of dependency, non-dependency on anything. Although we welcome the public-private partnerships, globalized business, and these joint ventures from the international agencies like UNICEF and WHO. Even UNICEF is doing exceptionally well in the areas where organizations is not performing so well. So with the Bill and Melinda Gates Foundation, which is an international NGO, is spending resources in Bihar, state of Bihar, over nutrition and other projects. Especially they are focused on women and child nutrition. So with the Indian government like ICMR and other agencies. So we are working in a joint collaboration. But the concept of Atmanirbharta, as per my limited understanding and experience, it is more of dependence, that we must not dependent on anyone.
Okay, all right, fine. Let's move to my other issue, which is what you mentioned, which many people don't mention and many people don't realize, that state is a health subject. And what do you think are the practical implications of this setup in India? To what extent are the chief ministers fulfilling their role? They have supposedly the power under the constitution, because it's not the prime minister who's controlling health, it's the chief minister, because that's what state subject means. And yet people think, I believe, what is the prime minister doing? And the prime minister should say, I'm doing my job, and that does not include health. It is a state subject. But no prime minister says this. They all appoint health ministers, and somehow, and I'm not saying this about any one prime minister, they don't want to give up the appearance of power over everything right from the start. Okay. They should simply say we don't have a health ministry, or we have a very small health ministry. But in practice, what is the implication of this that you see?
Sir, as I already said, that every state have its culture, every state have its demographic disparity. So it is of utmost important that state must be a health subject. Health must be a state subject. Because when we do outreach sessions, like if I don't know Gujarati, I may not be able to connect with the people of Gujarat. Same as if I go to Odisha for work, I may not be able to connect with the people. Okay, so health promotion, and if we want, like for the tobacco cessation campaigns, we usually do behavior change therapies and all these outreach sessions and promotion activities. So it should be done in the local languages, which is in correspondence with their culture as well. Every state have its own culture. Every state have its own language. So state has to be health has to be a state subject for its better implementation. And every state have its own challenges. Like in northeastern states, we have geographical challenges. Okay, there are more population of scheduled tribes people there. So they have their own cultural barriers. They have their own challenges. Like they in tribal areas, sickle cell anemia is more prevalent. In urban areas, pregnancy anemia and like iron deficiency anemia is more
Hmm.
prevalent. So we must have to plan different interventions for different group of people, different states, and how we will able to super overcome these geographical barriers, these cultural barriers. So for that, state has to health has to be a state subject for its better implementation. Even we distribute the information education uh, templates, like what I distributed during my internship for breast cancer and cervical cancer. It was in Gujarati, so that they will able to understand it better way. What the health ministry is doing at national level, union health ministry, we are having two types of schemes, like centrally sponsored scheme and central scheme. So centrally sponsored schemes in which we are having like health, state government is contributing certain amount, and the union ministry of health is contributing certain amount. So it is just, we can say ki health is working in a cooperative federalism model in India, just like other things in GST and all those things. That's what the Union Health Ministry is doing, and that's why they release the guidelines, not laws, because we can modify the guidelines as per our state needs. Another thing is, like you asked about what chief minister is doing and what. See, health secretariat is a bureaucratic network. they are experienced in the secretaries and all are experienced in implementing the programs, but and they take technical supports from the academia, from the professors and all. So it was always a collaborative approaches because the bureaucrat is having his own limitations. The academic people like us, what we have designed, we have our own limitations. So we have to discuss and then it should be implemented. So that's what our limitation. And for this thing, health must be a state subject.
Okay, wonderful. Uh, I agree with you on that mostly. I'm not an expert at all. But okay, now let me just try to provoke you by saying something in one sentence and let's see what your reaction is. Okay. I'm now talking about NCDs. Okay. So I'll put it in one sentence that prosperity is toxic in India.
Uh, if we see like that, then it is, and it depends on what kind of prosperity we are, because everyone is having their own personal version of prosperity. There is a prosperity in knowledge, there is a prosperity in money and status, and there is a prosperity in power. And and every of these types is having their own pros and cons. So prosperity in knowledge
So
has
I'm
its
talking about
own
prosperity of
intentions with
I'm talking prosperity of income.
prosperity of income. Yes, like in India, what I have observed that we are not merely educated about the financial system and how to use our finances, okay, judiciously, I would say. Because for example, in India, I have observed that the youths are using iPhones on EMI. Like it is just a cell phone. It does not require a loan or these kind of things. And you are earning an income just of 20,000 rupees. How will you pay the EMI of the
Yeah,
80,000 rupees phone?
yeah.
So prosperity, if you keep it with you, if you invest it in a right, if you get the return on investments and it is for the betterment of the country, you are paying the taxes in a right manner, you are not corrupting the system, then the prosperity of income is really good. But the prosperity of this kind, what I have mentioned, and there are so many examples of it, like people are spending on clothes, that too on EMI, or in made clothes and all. See, everyone is having their own interest, but for those interests, we need to earn that much. If I earn 2 lakhs per month, I will surely purchase an iPhone. But if I am earning 20,000 per month, I must not purchase an iPhone just to show off in front of my friends and in front of the society that I use a high-end mobile phone. So that's how we can use prosperity of income.
My point is to what extent is prosperity responsible for diabetes and cardio issues?
To very much extent, sir.
Uh,
Because diabetes and cardiac issues are lifestyle disorders. More the prosperity, there is a simple equation: more the prosperity, more the comfort. So, it is just like that. We are moving towards the packaged foods. Okay, we have almost 50, 60 types of drinks, but still we are drinking uh, like carbonated water and carbonated drinks. In India, as I said, that every culture has its own cuisine. Rather than trying that, we are going towards the burgers and pizzas. Of course, it is okay to do that, but we are doing it unimaginable manner, uncountable times, and that's what the uh, increasing the burden of non-communicable diseases. Comfort level has been rising up to that much that nobody wants to walk. Like I have a campus, I have to if I want to go out, I have to walk 1 kilometer. For that, certain people use their own vehicle. So was they prosperous enough? But if they walk for if they walk for 1,000 2,000 steps, their health will be at least improve a bit. People are not using public transport. Of course, there is a different issue for using public transport, but still. So prosperity comes with comfort, and the non-communicable diseases also comes with comfort.
That's what I'm saying, that they come with comfort. And we used to celebrate occasionally because we didn't have the money. Now we can celebrate every day. But that celebration ultimately takes a toll on our bodies. We have
Exactly.
to, we
It's just
cannot,
like
go
we
ahead.
must be conscious enough
Yeah,
about our spending, about our habits. Like what I live in hostel and I'm observing that there are many people who are awake till 3 a.m. No, what is the need to do that? It is just weakening your circadian rhythm, weakening your like immunity, and making you more prone to certain diseases. And stress and anxiety are also one of the chief predisposing factors for in young adults actually. See, we cannot uh, discard the stress and anxiety. It is a fate. It
yeah,
is not in our hands. But dealing with it is in our hands. How we deal it is in our hands. So if the stress is coming, we cannot say, okay, go. But how we deal with it in correspondence with the health, that is in our hands.
all right. Now, one sort of uh, I'm thinking that I want to ask you a question, but right now it's slipping my mind as to what that issue is that yeah, okay, sure. It's a personal question and you may not answer. Have you lost a lot of income switching out of dentistry to this kind of work? It took you 2 years to do this course you are doing, some internship and all. So what do you think? The financial loss was worth it? What motivated you to give up the income loss? And you, as you said, that when a person goes to healthcare, poor person, the double loss, one is the income loss, the other is the payment. Well, in your case, the double loss is that you didn't earn and you were paying tuition or something or the other. So how do you explain that to us? Why did you do it?
Well, that's what I would like to go back to my internship days because it has been completed in 2020. So every hospital was closed, only the COVID treatment was going on. And that continued till almost 2.5 years. Like COVID comes in waves, and even the unlockdown was also came in waves. So uh, at that time, I was working under the CMHO in Thor, right after my internship. So for some time I worked there. Then after the first unlockdown, I came to my parents' place. Then after again second week here. So again I was not able to work in hospitals, and I was not into the plan to open my clinic, my own clinic at that time. After that, what I realized when the market was shut down and when it reopened, there was a high price of equipments, especially medical equipments. And for the dental clinic, we must have certain high-end equipments for better treatment. At
Yes,
least in private clinic, at least in
yes,
private clinic. So the what I observed that return on investment of in the dental, opening the dental clinic was not so good. Since I was passionate about the civil services, so I got the opportunity in those 1 to 2 years to prepare exams. But somehow I cleared. In some exams I failed, and it was quite time taking. So without wasting further more time in those things, I just wanted to upskill my thing that if I want to work for public and for community, public health, because it was costing the same, at least it was costing the almost same as opening a dental clinic and pursuing my master degree.
I see. Okay. Right.
Almost same, and even my master degree will complete it in less cost actually. So if after the master degree I'm getting a decent job, I must not go there, and it will help me in upskilling myself, gaining the knowledge apart from the medical sciences and understanding the health systems. In that way, I may also work with the government. I will also work for the community. So it was satisfying my goals and agendas.
Okay.
So
So
after
you're
those two
then,
years which I wasted, which was wasted due to COVID, that was not in my hands actually.
yeah, yeah, yeah. Okay. All right. I think the time has come for the final word. What's your final word to the world?
Just stay healthy and be conscious about your health and habits. That's what I would like to say to the world.
Okay. All right.
Because
Thank you.
health is your asset, and I would say a prime asset. Because if you are healthy, you can contribute to your nation, to your community, to your society in a better way rather than being unhealthy.
Okay. All right. Wonderful. Thank you, Dr. Joshi. It was a pleasure to listen to you. I've had a couple of health experts, but everybody has a different view, different take, different story. So I'm glad we got your story. Let's end it here today. Stay online. I want to talk to you a little bit. I'll be back with another young person or an expert soon. Till then, bye everybody.
Thank you, sir. I'm honored to be part of your series.